So I really want to warmly welcome Dr. Robert Kyle this morning.
Well, good morning. Thank you very much, Jack, for those kind words. I didn't realize that you knew so much about Tommy Turtle. In fact, you know more about it than I do. It's a real pleasure for me to see so many patients with myeloma and related disorders here, as well as the caregivers that are so important to your well-being. In my 30 minutes this morning, I will talk briefly about multiple myeloma, our approach to it, and some of the studies that have been done to further our knowledge in this field that is changing very, very rapidly. There's been more progress in multiple myeloma in the last decade than in the previous 4 decades that have gone on before that. These are my disclosures. They're mainly data monitoring committees and the like of ongoing studies for multiple myeloma. This is the disease. These are the plasma cells that you have in your bone marrow that produce the protein that you see in your blood and or in your urine. This is the spike that many of you have in the serum. About 80% of patients with multiple myeloma will have this tall, narrow-based spike, church spire spike, it has been described as. The minimal criteria for the diagnosis of multiple myeloma is a bone marrow that contains 10% or more plasma cells, or histologic proof of a plasmacytoma, which is simply a collection of plasma cells, and an M. The M stands for monoclonal protein in the serum. It's usually greater than 3 grams per deciliter, but not necessarily. A monoclonal protein in the urine, which has been called Bence-Jones protein, or now is called light chains, or lytic bone lesions on X-rays or CT scans or MRIs. The most important point is that the patient with multiple myeloma has end organ damage. You can remember that by the word CRAB. C for hypercalcemia, that is increased calcium in the blood, occurs in about 15 to 20% of patients at the time of diagnosis. Renal insufficiency, kidney failure, about 20% of patients with multiple myeloma at the time of diagnosis will have a creatinine above 2 milligrams per deciliter, which is significant kidney dysfunction, or anemia, that is low hemoglobin, or bone lesions. These are lytic lesions as seen by X-ray or CT scan, or changes in the pictures of the bones with MRI. Now, there is an entity that we call smoldering multiple myeloma, and that is a situation in which the patient has a monoclonal protein in the serum, that is 3 grams per deciliter or greater, and or 10% or more plasma cells in the bone marrow. If you remember from the previous slide, this is the basic criteria for the diagnosis of multiple myeloma. But these patients do not have anemia. Their hemoglobin is normal. Calcium and creatinine values are normal. There are no lytic bone lesions. And the plasma cell labeling index, if done, is low. And this is simply a measure of the proliferating or growth of the plasma cells in your bone marrow. And these patients do not have end organ damage. This constitutes about 15% of patients with multiple myeloma, and it's very, very important that you not be treated in this situation, because your disease can smolder for over 20 years without progressing. It's also well to keep in mind the words of Professor Jan Waldenstrom when he described the epitaph on a person's tombstone: "I felt well but wanted to feel better. Therefore, I am here." And that's simply a reminder that any medication that we use has potential ill side effects. So the bottom line is don't be treated unless you need to be treated. Now, we approach patients with the so-called M-SMART classification, in which we divide patients who fulfill the criteria for the diagnosis of multiple myeloma, that is, active or symptomatic disease, into patients with high-risk disease, and that accounts for a quarter of the patients, or those patients with standard risk disease, which accounts for 3/4 of the patients. The patients with high-risk disease have, on cytogenetic study with FISH, that's fluorescence in situ hybridization, they have changes that are called deletion 17p or a translocation 414, 1416, or 1420. Or with conventional cytogenetics, the patient has a deletion of chromosome.